Okay, well, welcome everyone. This webinar is Low Value Care 101, Identify, Measure, Report, Reduce, and Report. My name is Michael Boudros. I'm the Project Director for VBID Health, and I will be helping to facilitate and moderate this webinar today. I implore you to ask questions throughout the webinar. You can do so through the Zoom toolbar. There's a Q&A icon on there, and you can submit questions to that. I will be facilitating a Q&A at the end of the presentations, so please submit any questions that you might have. And in addition to that, we are happy to continue this conversation after the webinar. My contact information is located at the bottom of your screen right now and will be also at the end of the presentation. So feel free to contact me if you'd like to learn more or get more resources. And in addition, a copy of this webinar will be made available at the end. It will be uploaded to the VBID Health website and the VBID Center website sometime today or tomorrow. And you should receive a follow-up email after this webinar, which should have a link to that. And if you would, we have started a hashtag Low Value Care 101. So if you're a Twitter person, we would be more than happy to have your tweets go out. If you find something interesting or something informative, we would much appreciate it. So today we are joined by Dr. Mark Fendrick, who is the director of the Center for Value-Based Insurance Design at the University of Michigan, and Beth Bortz, who is the president and CEO of the Virginia Center for Health Innovation, both leaders in both value-based insurance design and in the cutting edge of low-value care. The agenda today, first, welcome. Thank you for joining us. We very much appreciate your attendance, and we hope that this webinar will be informative and also actionable for you. I will start off the webinar by giving a short background and sort of a level setting on what low-value care is and why it's important. Mark will then take us into the value of creating headroom through low-value care, and then Beth will discuss the Commonwealth of Virginia's specific steps to improve healthcare value by tackling low-value care. And at the end, we will have a question and answer session where we will be able to discuss some of their points with the presenters. So starting off, what is low-value care? There is some distinction between different definitions and terms that people use commonly when we talk about overuse or waste. And they're often used interchangeably, and they for most purposes can be. Waste typically captures all different types of inefficiencies in the healthcare system, like administrative waste, which would capture complexity of the healthcare system in general, or operating waste, which would capture duplicative services or other things. Our focus today, and with VBID Health and our low-value care efforts, is primarily on clinical waste. And we are foremost concerned with two specific types of clinical waste. One being medical care that is harmful or where the harms outweigh the benefits. And a potential example of this, and we'll go into more detail later, would be something like a prostate-specific antigen screening for men over 70, broadly understood by both the U.S. Preventive Services Task Force and clinical communities to have more harms than benefits, especially at that age, and can result in a variety of cascading harms that clearly outweigh the benefits. There's a second type of clinical waste, medical care waste, called that we refer to as care that offers no benefit over less costly alternatives. And an example of this would be using branded drugs when a chemically identical generic is available, which is more of a resource allocation problem than harmful, but you're not buying any additional health per dollar. So low-value care, the term sort of captures the clinical nuance, more so perhaps than the clinical waste. And it recognizes that services differ in value depending on patient, provider, when it's received, and so on. So we like to use the term clinical waste, or I'm sorry, low-value care. But why address waste at all? First, it's the magnitude of the situation. There is a large amount of potentially wasted resources based on current research that could be used for better things. For example, in 2012, there was an analysis that up to 34% of spending on healthcare is wasted. This includes administrative waste and this operating waste that I talked about before, but clinical waste is certainly a part of that. And then there's also 21%, there was a physician survey that estimated about 21% of care that's used is unneeded, which in terms of utilization is a lot. But in terms of dollars, we see that estimates vary significantly, but there's upwards of $765 billion a year spent on low-value care is a particularly large problem and is a resource allocation crisis. The bottom line, even though the estimates vary, the bottom line is that it's pervasive and costly. And we also just don't really know the true extent of how much we spend on low-value care. There's a cascading downstream harm and medical costs and out-of-pocket costs associated with low-value care that we don't actually know, and there hasn't been a systematic effort to measure it. And that's one thing that we will address today. So at the core of this, there is first the financial magnitude and burden, but there's also at the core this harm to patients. There's a financial and also ethical urgency to address low-value care. It's pervasive, it's costly, and it's also harmful. There's the direct physical harm associated with services that are low value. These services often either cause harm or they might have incidental findings that create worry and harm in the future. There's cascading downstream harm and costs related to these incidental findings or other situations related to low value care. There's the opportunity cost, botherness, and the exacerbation of health disparities that come from low value care. There have been studies that that show that racial minorities in particular are more likely to receive low value care. And out-of-pocket costs. Patients end up paying out of pocket for care that doesn't buy them additional health, which is a problem. And sort of one of the reasons I bring this up, the harm specifically, is that when, in terms of communication at least, harm to patients is very salient. There's been research to show that focusing on harm is one way to communicate low value care in a way that is meaningful and can move the ball forward. And one thing that we've discussed a lot at VBID Health and is sort of undergirding a lot of our current projects is that we believe that there's an untapped opportunity for state leadership. And Beth Bortz, who will speak later, is definitely a jewel of state leadership in low value care. States have unique political pressure and spending pressure that is different than the federal level. And so we think that combined with the fact that they have this APCD data, all payer claims data, combined with tools that are already available, that they're powerful stakeholders in measuring and reducing and reporting low value care. So we are very much excited to discuss state opportunities as well. And we've, VBID Health in collaboration with Altarum has released this concept paper on state leadership that you can find online. So what can be done, and this will be the focus of our webinar today after I'm done talking. We will discuss efforts to identify low value care services and that are the most appropriate for systematic action, measure the utilization, spending, and waste index, so to speak, of these services, how to reduce the spending and use low value care services, or reduce the spending and use of low value care services through multi-stakeholder collaborations, which is very important, and how we might go about reporting this to maintain that momentum. And these steps are not necessarily linear, but we think that's a simple framework to understand what we're doing. So to start us off, I will hand things off to Mark, who will now discuss headroom.
Michael, thank you very much for that great table setting. And I would like to thank at least 215 of our colleagues who've taken time from their busy schedules to tune in to Low Value Care 101. I am extraordinarily pleased to share my time with my colleague and low value care superhero, Beth, who has really made things happen. In addition to my talking the talk, which many of you on the webinar know my incredible trend and tend to do so, Beth has really made this happen. So lots of information on low value care efforts on the VBID Center website, which is shown here. And I'm hopeful that we'll be able to get some Twitter followers using the hashtag Low Value Care 101 that Michael spoke to. So next slide, Michael, please. So the goal of value-based insurance design, and why I like to speak on headroom before we get to the amazing opportunities to identify, measure, reduce, and report low-value care, is to remind us that we are in the healthcare business not to save money, but to improve health of individuals and populations. And even though in my 25 years of a practicing primary care internist, it's been remarkable what we can do to improve the health of individuals and populations, it seems to me that almost all the discussion regarding healthcare transformation revolves around healthcare spending and reducing healthcare spending. And I like to tell people two things. Is one, I did not go to medical school to learn how to save people money. And secondarily is that unlike education or transportation, there's more than enough money in the US healthcare system. We just spend it in the wrong places. And the goal of clinical nuance, value-based payment, and value-based insurance design is to hopefully reallocate spending to more of the good stuff and less of the bad stuff, and ultimately change the healthcare discussion from how much we spend to how well we spend. Because I'm very happy to not have the jobs of many of you on the line today. The tension between improving population and individual health and cost containment is only going to get worse. I, as a clinician, are extraordinarily excited about what I can and will be able to offer my patients. I call this Star Wars science. Next slide, Michael, you keeping up with me? And unfortunately, when you keep hearing about the substantial underuse and the underinsurance of many Americans, our ability to deliver these amazing innovations, I like to call that Flintstones delivery. Next slide. So what we're really trying to do, next slide, Michael, please, is to really hammer down this very, very important point as we try to bring American healthcare delivery from the Stone Age to the Space Age. And this, I think, is probably the most important point I would like to make, not only on the area of low-value care, but healthcare transformation in general, is that Americans really don't care about healthcare costs like almost all of you on this webinar. They care about what it costs them. Thus, our focus at the VBID Center to try to reduce out-of-pocket costs and mitigate cost-related non-adherence for those high-value services that I beg my patients to do, which I'm often benchmarked on, and my clinical colleagues are actually paid their bonuses in these new alternative or value-based contracts. Next slide. So the implementation of clinical nuance, many of you know, is called value-based insurance design, but I have to put a pitch for VBID in, is that as more and more Americans are not only paying more out of pocket for all healthcare services, these blunt instruments such as co-payments and co-insurance, which used to worry me, but now deductibles, where Americans don't have their insurance kick in at all until they meet their deductibles, is really the motivation for us to not only look at high value services, but as low value services. A typical insured American has a $1,000 deductible, even if they're not in a high deductible health plan. And the Federal Reserve released a report a few months ago reporting that 40% of Americans don't have $400 in the bank. So this creates a rub to somehow change the system such that out-of-pocket costs are aligned with value, not price. And some of you on the line know I've been sounding like a broken record, which is a term my kids will never understand. For 20 years, talking about implementing value-based insurance design, we continue to make some progress and happen to have very rare bipartisan political support. Next slide. So why low-value care? And many of you say, I wanted to be remembered as a person who made high-value care accessible and affordable. And as a small role in the value-based insurance design portion of the ACA that has removed consumer cost sharing now for over 80 high-value preventive services, does suggest the very important point that we want to make, that healthcare is typically paid for in two portions. I call the entire healthcare cost an iceberg. What my patients pay is the tip of the iceberg, and what other payers pay is below the waterline, and you can see by the next slide, very importantly, what patients pay is determined by their insurance coverage. So while all of you on the phone are typically trying to look at the total iceberg part, Americans tend to care only about the tip of the iceberg, since that my patients who get their no-cost pap smear, mammography, colonoscopy, LDL screening, hepatitis C screening, they don't care or ask about how much the test costs. They're just very, very happy to know that their coverage allows them to pay very little. The next slide will show you that in the situation now, many Americans and several of my patients are in the deductible portion of their high deductible health plan. It's very important to know that patients are now paying the entire iceberg cost. And in some situations, they're actually paying more than their health plan pays because of arrangements that often come with negotiations with third-party payers. Next slide, please. So we want to get to the situation where patients will pay little for high-value care. And I know every payer on the line now is just saying, you know, Mark, you've been talking about this for so long. This is a webinar on low-value care. How does this relate to VBID? And what you'll tell me is that I try to extend lower cost sharing for high-value services. In the situation, the water line will rise. That means the third-party payer has to pay more. Next slide. Where are we going to get that money? So sticking with the low-value care and high-value care iceberg scenario, imagine that we have two icebergs, high-value care icebergs and low-value care icebergs. At current amounts, patients are being faced with equal amounts of cost sharing independent of the value of their care. And what I would like those of you on the webinar to understand, that if we were to melt exclusively the low-value care iceberg, next slide, as the low-value care iceberg shrinks, the water level allowing you to cover high-value care more generously can actually occur. So this is what we call headroom. By the identification, measurement, and removal of low-value care, we could hopefully take some of those billions of dollars of savings that Michael talked about and not just remove them from the system, but hopefully incrementally apply them to more generous coverage for high-value care. Next slide. So as we go through our four verbs, we and many organizations across the country have focused for decades to identify low-value care services. We are amazingly thankful from the national and now international leadership of the Choosing Wisely campaign that has now led to scores of professional societies to identify services that are potential for overuse. Some or all of you might know that the U.S. Preventive Services Task Force, which actually identifies those A and B rated services that are mandated to be 100% covered by non-grandfathered plans. They also have services that acquire what's called a D rating, which says that these services are dangerous and should not be used. And so there are a number of ways that we can identify low-value services to get our toe in the water, so to speak, to make a movement to shrink that low-value care iceberg. So Michael Chernew and I created something called the Task Force on Low-Value Care. And we wanted to call it the Waste Task Force, but WTF acronym was already taken. And we assembled stakeholders across the purchaser community, public and private, from across the country. And if you could go back for a second, Michael, we did not want to find the services that were the most harmful. We did not want to find the services that were most dangerous or costly or prevalent. We wanted to start in a baby step way for purchasers to make it easy for them. So the task force went through over 80 services and wanted to go back just one more second, sorry. Go back and identify those that were available to purchasers in forms of their claims, that when they were used, they were mostly used in a low value situation. And most importantly, for the human resources people on the call, is that when we were going to be successful in the reduction of low value care, we wanted situations where the phone didn't ring. Because anyone who's ever tried to remove a benefit of any kind understands that there will be some type of negative reaction by taking something away that has already been in place. So we went around and around and around and around. And the next slide, I think, which is the most important, and if any of you have your cell phones, I would love you to take a photograph of this slide, which are the top 5 lists that the Task Force on Low Value Care chose that would be the easiest 5 services for a purchaser to act on to get moving on a targeted or nuanced low value care campaign. These include diagnostic testing prior to low-risk surgery, most notably cataract surgery and breast biopsies, population-based vitamin D screening, which many of you know has been my flagship low-value care condition, PSA screening in men over 70, since we wanted to have a Medicare measure, imaging in the first 6 weeks of acute low back pain, as well as a service that Michael tended to mention, the use of branded drugs when an identical generic was available. These we feel are actionable, and it's my hope that the purchasers on the line would choose one of these 5, if not 5 of these 5, to actually follow the lead of Beth and many others around the country to not only identify them, but measure their impact and hopefully reduce their utilization. Next slide. So we have developed with Milliman a tool called the Health Waste Calculator, which is among several tools available to you on the purchaser side to help you measure how much you're actually spending on an annual basis, or even more frequent than annual basis, on these low value care services. The current version that Beth used included 47 services. We soon to have a new version with 400 low value services. And as I said, this product is co-branded with VBID Health as well as Milliman Med Insight. Next slide. So Beth will talk about our flagship and most notable Commonwealth, the one from Virginia. But we have worked with other states, and this slide really briefly summarizes the work of the State of Washington Health Alliance, which ran the Health Waste Calculator, which not only identified an incredibly high, near half prevalence of folks who had claimed being exposed to one low value service, but they did find over $250 million in no and low value care, which is enough to bring attention to most key stakeholders. Next slide. So moving on from measure to reduce, I think this is the hard part. We've made great headway in the identification and measurement of low value care. I don't think anyone has done anything more on a statewide basis than Beth in Virginia. I include on this slide a list of levers that Michael Boudros and I included in an editorial in the American Journal of Managed Care. There are lots of ways for us to consider potentially the reduction of low value care. Since there's been so little real world implementation of these levers, I can't tell you personally from an empirical or database type decision which ones would be most effective. As someone who's worked pretty much on the patient-facing side in my career in benefit design reform with value-based insurance design, it is my impression as we go into the evaluation phases that most of the utilization of low-value care is actually provider or supply-side driven, with few examples notwithstanding, and that it's the levers on the left side of this slide that I believe to be most impactful in the reduction of low-value care. I have argued for a decade that alignment of provider-facing or peanut butter and patient-facing or jelly incentives are the way to get more value out of the healthcare system. I think they're more equally rated on the way to get more people to get high-value care. I'd like to think going in that the levers that will have the most impact in reducing low-value care will be more on the provider or peanut butter-facing side. Next slide. So I'll leave you with this. I hope some of you at least know of Section 2713, which is the part of the ACA that requires us to cover high-value preventive services at no cost to our patients. In our work in the ACA around clinical nuance and value-based insurance design, there is another section that I believe that none of you have ever heard of, which is Section 4105, which clearly states that the Affordable Care Act grants the Secretary of Health and Human Services the authority to eliminate coverage for U.S. preventive services, D-rated services in the Medicare population. This includes prostate cancer screening over 70, as I mentioned, and also colorectal cancer screening over the age 85, and there's a few others. But why I bring this up to close my remarks is there is already regulatory guidance to help you, purchasers, whether you use the D-rated services in Medicare as described by 4105, or the D-rated services that apply to a more commercial or a Medicaid population, that this, in my opinion, is the easiest place to start. The same organization that provides you one of the most popular aspects of your benefit design, that being those services that are A and B rated by the task force, also on occasion will identify services that should not be prescribed at any price. And it's been my challenge now for many years to identify a plan that is willing to move forward either through supply or demand side levers to try to reduce these no value services in a way that will hopefully free up some additional dollars for us to be able to purchase more services that improve individual and population health. So with that, Michael, I'm very happy to turn this over to my colleague Beth, who will not just talk the talk about identification and measurement of low value care, but tell us how she's actually walking the walk in the Commonwealth.
Beth, make sure you're not muted.
Hello, can everyone hear me?
Yes, thank you.
Thankfully, yes, I was holding my breath. I was about to turn purple, Beth. Good afternoon.
I was too, but the system finally allowed me in. So good. Well, hello, everyone. Thank you so much. I'm delighted to work with Mark and Michael to share with you a little bit about the Virginia story. We have very much wanted to be a part of this work to improve value. It's what we do. Michael, if you'll go to the next slide. So let me tell you just first a little bit about the Virginia Center for Health Innovation and why we're positioned to lead some of this work in Virginia. We are a 501c3 nonprofit with a mission of accelerating value-driven healthcare. And we have a very diverse multi-stakeholder board of directors. Next slide. And I think this piece about us being a public-private partnership and the diversity of our stakeholder board is a really critical one for folks to understand. Because as I like to tell people, one, VCHI has no financial skin in the game. So we can work really hard to promote data transparency and letting the chips fall where they may. And so we're just uniquely situated. We were created by Virginia's governor as a response to what he had, the Virginia Health Reform Initiative after the passage of the ACA, really with the recognition that in Virginia, the Virginia way would not be to drive this through state government, but would instead be to bring all the partners together to work on this. And so you see in this slide, our founding partners really covered the gamut from, providers, labs, pharma, health plans, employers, the safety net, the health systems, all engaged. Our founding chair was our Secretary of Health and Human Services, Dr. Hazel. Our current secretary, Dan Carey, also serves now on our board of directors. We were housed at the State Chamber of Commerce at our founding. We now, since we've grown, we are now housed at Virginia's Association for Federally Qualified Health Centers. Next slide. You can see here we have a board and an advisory leadership council, and I just give this to you so you get a sense of kind of the depth and breadth of our members and the input that we get from the front lines in healthcare in Virginia. Next slide. So the work of the center really covers 4 core services, but today I'm going to focus primarily on number 3, which is leveraging data and analytical resources to inform and enable healthcare providers, public health professionals, the government, community organizations, employers, and consumers to make better decisions. So this is that role of kind of bringing data to light to drive improvement in the Commonwealth. Next slide. So what did we do and how did we get involved in this work? When we were getting started, we felt it was very important that we choose as one of our initiatives something that crossed all interested parties. So unlike many states who focused their innovation work solely around the expanding Medicaid population, we were looking for something where we could build consensus across all insurance types, all regions of the state. And so we decided very quickly that a place for us to work on was reducing low-value care. There seemed to be a lot of interest by employers. There was interest and willingness to have the conversation by our providers. And fortunately, choosing wisely was at the forefront of the national conversation, and there seemed to be consensus around that campaign. We believed very strongly, and still do, that an initiative where the physician community had identified themselves those tests and procedures that needed to be addressed had the greatest likelihood of success. So, we started there with the identification piece. Then we went into measuring. How do we get the data? How do we know what's happening in Virginia? Because I will tell you from years as a performance evaluator of policy programs, I wanted to know what's the baseline and how do we know if we're making a difference. It's not just enough to launch a program and hope it does good. So we really wanted to make sure that we could measure. The next step for us was about reporting. How do we share that data? And I will tell you, I joke with Michael and Mark that I've switched the order of their 4 verbs here. We report first, and then we work to reduce, and then we will report again. So it is very cyclical, but we really had to work on the reporting as a third phase, and then finally to get to that reduction. How do we test different strategies? Because the truth is, as Mark shared with you, the different strategies, we don't really know yet which ones are going to be the most effective for particular tests or procedures that we're concerned about. Next slide. So I mentioned the first step, identify. This was really building consensus for us. Could we get everybody in the Commonwealth agreed that this was going to be a priority? And so I just list here probably about 1/3 of the presentations that I did over a 1.5-year period of time to really go out, talk with folks about this idea of measuring unnecessary care in Virginia, building consensus that this is something we wanted to tackle. And the good news is that from all these different entities, the resounding feedback that we got was this is important. Next slide. So then measure. The question became, could we get that baseline data? Could we start to identify how much of this was happening? And this is where our partnerships were very critical to our success. So in Virginia, we are very fortunate that the Virginia General Assembly, the Virginia Association of Health Plans, the Virginia Hospital and Healthcare Association came together and worked with Virginia Health Information to launch an all-payer claims database. And at the time that we were starting to really want to get baseline data, that APCD was robust enough that we could use it as our data source. And so we used the state's all-payer claims database with the Milliman MedInsight Health Waste Calculator and looked at the claims data for 5 million Virginians. Next slide. So the data that you're seeing today is from version 6, which has 42 measures. We should have version 7 ready to go in about a month. We're super excited about that because I think, as Mark mentioned, that has additional measures, and that resource is only going to grow. And I think that's important for people to recognize. If you look at the National Choosing Wisely campaign, there are over 500 tests and procedures that have been identified as unnecessary or low value. So we are looking at a very small portion of the potential. We are looking at ones that at least initially lend themselves best to claims data. As Mark shared with you, some of these, all these measures are clinically nuanced. Some will require clinical information that isn't available in claims data in order to really determine how necessary it was. So it's important to know that the waste calculator that we use really focused those initial measures on those that were most applicable to claims data. And you can see there kind of where the sources for these measures that comprise the 42 came from. And again, many more measures in the pipeline. Next slide. So in terms of our data, you can see there's one of the challenges moving forward is there's a little bit of a data lag. So in January of 2019, we could release results through December of 2017. So there's about a year lag right now. We're working to shorten that time period. But I want to focus your attention on the last two numbers there. So just those 42 measures in Virginia, 747 million per year. And that represents over 2 million unnecessary services. Next slide. You can imagine those numbers, and we've actually been putting those numbers out now for 4 years. We started with 2013 data, and those numbers have been fairly consistent over time. Part of the road tour, if you will, that I continue to do is to let folks across the Commonwealth kind of kick the tires on the data, and to do a deep dive of that data. And the good news is that the data seems to be standing those tests. We have had state health systems compare a regional data analysis that we've done to their own data through their EHR, and it seems to be fairly consistent. So that's good news. Bad news, you can see in Virginia, 39% of members were exposed to at least one low value service. 35% of services measured were of low value, and that represents real money. That represents over $11 per patient per month in unnecessary claims. Next slide. So here you'll see the top 5 measures that we had, and this is by cost, and it's a proxy cost, but this is by cost. The thing I want to draw your attention to here is that first one. If you remember Mark's list of the National Task Force top 5, our number 1 is their number 1. This is the labs for low-risk patients before low-risk surgery. This is a big one, and this is the one in Virginia that we really are going to focus on. Next slide. So we are also we have lots of ways we can slice and dice the data here in Virginia. I just give you this as an example. We are able to run the reports thanks to our friends at Virginia Health Information by region of the state. And you can see there are some fairly significant regional differences. We have actually looked very closely at Southwest and Northern Virginia. Health systems in those 2 regions have actually asked us to do a deeper dive of their performance. And I can tell you, not only is the percent of members different, but the things that comprise the unnecessary services in those regions are different. Both have the same number 1, and it's the same number 1 that we have and the same number 1 that Mark has, that, testing and imaging for low-risk patients before low-risk surgery, but there are differences when you get, 2 through 10. Next slide. So, after we started running these reports, we get to step 3, which for us is the report, really sharing that data. And some lessons I would share with you all if you are considering doing this in your state or in your organization. It's really important that you think about the audience that you're talking to. And I have learned this the hard way as kind of the pioneer speaker in this area. So if you are speaking particularly to physicians, you don't want to talk about waste. They get very unhappy if you are suggesting that they are doing wasteful things. If you talk to them about low value, that they might make better choices, the receptivity changes. So we're very cognizant of that. I will tell you, employers, it's kind of the opposite. Employers, you use the word waste, and now they want to sit down at the table with you and they want to identify that waste and eliminate that waste. So, you know, it just depends who you're talking to. Similarly, what I have learned is that not everyone's first concern is tackling the top 5 by cost. That's how I initially approached this. You saw my top 5 list by cost. But I have had very good conversations about different ways of approaching this. So for example, our state employee health plan, when they first reviewed data, they said to me, cost is important, but we want to show our employees that we want to focus first on reducing harm. And so of those measures in your 42, which ones have the potential to cause the most harm, and can we focus on those first? That was a great argument. Similarly, when I shared this data with the chief medical officers of several of Virginia's leading health systems, they said to me, well, harm is important and cost is important, but if you want to have a win, we think it's important that you choose tests and procedures that we are performing inappropriately the majority of the time. So for example, you could have something like an EKG, which is expensive and shows up as a top cost, but 97% of the time, clinicians are getting it right. They're ordering it correctly. You could have something, and I'll select Dr. Fendrick's favorite vitamin D screening, that's not nearly as expensive, but it is being ordered inappropriately a great deal of the time. And so their message to me was, think about choosing things that aren't needles in the haystack out of the gate. We've also learned we have to be prepared to address provider medical liability concerns. So, you know, the good news is that all of these things come from, you know, evidence-based medicine, from approved best practices of the medical specialties themselves, but it's really important that you arm providers with that information. And then some of these measures, consumer education is going to be a bigger piece than others. If you look at the full list of 42 measures, you will see some things where consumer behavior is going to be more relevant. Things like requesting antibiotics or imaging for low back pain. That's much more likely to be important in those cases than perhaps in some of the labs that are ordered before a low-risk surgery, or for PICC lines for in certain medical cases. So you typically don't have patients asking for those things. So again, your approach is going to vary based on you know, who is influential in asking for that service. Next slide. So you know, I am not a researcher by training. I am a convener. I am a policy person. But you know, as we started to get this data, my peers, Dr. Maffei at UCLA, Dr. Fendrick, and our team here in Virginia decided it was really important that we start to get the word out. And so we submitted a piece to Health Affairs, and we were delighted that it was the 3rd most read article in 2017. And so that brought additional conversations about what to do. Next slide. So as we started talking more and more about what were we going to do to reduce low value care, I will tell you that one of the concerns that was most frequently raised was, well, what happens if you do a great job of reducing all this low value care? You create the headroom that, you know, Dr. Fendrick is talking about, but none of that money gets reinvested, right? That money all just gets pulled from the system. And then we're going to feel very defeated, because while we will have done a little bit to improve value in healthcare, we won't have done as much as we could do if we reinvested some of that funding back into the high value care side. And so hearing that dialogue, we decided here at the Virginia Center for Health Innovation to create a health value dashboard. The health value dashboard is an attempt to really show both the importance of low value care and high value care services across Virginia. So if you go to the next slide. Okay, one more. So on our dashboard, we have 3 aims: reducing low value care, increasing high value care, and improving the infrastructure for value-based care. And I will tell you that third one is really important. When we first started, all the discussion was around those first 2 aims until we realized that many of the measures we wanted to include under aims 1 and 2, we couldn't, because we didn't have the ability to measure the things that we wanted to measure. And so this piece about the infrastructure is really important. The other thing I want to share with you is that it took a lot of hard work, and I want to thank my board and advisory leadership council, which represents about 50 some organizations, to have as few things on this dashboard as you're seeing. Because as you can imagine, we started out with a list that was in the hundreds of things that people thought were important to include on the dashboard. And my mantra here at the center is people cannot move the needle on more than a handful of things. And so these are our handful of things. Next slide. So on the low value care side, you'll see there's 3 there. The middle one, B, is really this piece that we're talking about of low value services captured by the health waste calculator. The other 2, inappropriate preventable hospital stays and avoidable emergency room visits, were just naturally important measures for the Commonwealth of Virginia. Next slide. On the high value care side, it's pretty straightforward. It's immunizations, it's diabetes care, and it's cancer screening rates. Keeping it simple. These are also all things that all of our health plans in Virginia are already including as part of their incentive-based contracts. So it was important to us in creating this dashboard not to create new measures that were going to make it even harder on our providers here in Virginia. Next slide. And then the third one I mentioned, the infrastructure piece, and I would just focus on that second one. We rely very heavily on Virginia's all payer claims database for the reporting and work that we're doing. So, and prior to this legislative session, our all payer claims database was voluntary, and so it was very important that we see a high percentage of claims being submitted. I believe that is changing as of last week, and all for the better. But it was very important to us to make sure that we had the data there. Next slide. I don't want to let you think that I was so successful in keeping our number of measures down to a minimum, because the dashboard is always going to be a work in progress. There are always going to be new things that we want to measure, or things that we knew from day one we wanted to measure, but we didn't have either a good measure or a good data source. And so we will continually be working. We have a future measures work group that is constantly talking about measures that we want to add to the dashboard. And here you just see a sample of those. Next slide. So then we come to the part of, okay, we have built consensus. We have identified a tool to create the baseline data that we needed and make a compelling story. We did the roadshow. We got people to look at those reports and to care. I should mention to you that that dashboard I was just talking about, that's actually funded by our Virginia General Assembly. That's important. That shows how important they think this is. It also conveys to stakeholders that work with the General Assembly that this is important. So all of that led to the place where we are now, which is, okay, now it's time to fix it. And how can we fix it, and what can we do? And we're really excited because we are at the jumping off point. And I want to take a second and thank Virginia's federally qualified health centers for kind of being our guinea pig, our first in line, early adopter. Their association raised their hand and said, hey, can you run dashboard reports for each of our centers? And then can you do a combined report? And can we start to figure out where we could do better? And so we have done that. They are starting to share some really exciting data. And I can tell you that data is being very well received at the federal level. So that is something that will be ongoing. We've shared reports with our state Medicaid agency and our state employee health plan. Both are fully on board to do a statewide initiative with us. As I mentioned, both our previous secretary and our current secretary have served on the board of this organization, and so we're excited to have both of them at the table. You can imagine that given their magnitude, they can leverage relationships in ways that we can't. And then finally, let me close with, hopefully very soon, you will be hearing from us about a large health system collaborative. We have had 6 of Virginia's health systems that represent over 1,000 practice sites come forward and raise their hand and say, we want to work on Drop the Pre-Op. We're interested. And that has been matched by the employer side of the house, where both the Virginia Chamber of Commerce and the Virginia Business Council have said, we want to work on this too. We understand that part of our role is to encourage the health plans to change the incentive structure. And so we're hoping that that health system collaborative working with the employer task force leads to meaningful change. Next slide. So that's where we are in Virginia, and I look forward to taking your questions.
Thank you, Beth. Sorry, I had to unmute myself. Thank you, Beth, and thank you, Mark. We really appreciate everything that you guys have presented on today. We have a number of questions, probably too many questions that we can get to in the next 8 minutes. But first I wanted to say we got a number of questions about the health waste calculator, and in an effort to triage our time here, I will be providing you some contact information about the health waste calculator to get better information about the new services that will be on next iterations and next versions. So I'll be adding that to the slides afterward. But the first question I'd like to ask, there was a question about the appeals process and how clinically nuanced plans are willing to be. And I think Mark would probably like to address this question.
Yeah, thanks. Beth, that was incredible. Thank you so much. I think as we go through there and we talk about high and low value care, again, part of my job is to remind people that there's no clinical service that's ever always high value and low value. That's the underlying premise for this idea of clinical nuance. And when I tell people my 3 favorite high value services, I tell them it's colon cancer screening, coronary stents, and back surgery. And when I tell people my 3 favorite low value services, I tell them it's colon cancer screening, coronary stents, and back surgery. So the question about appeals is extraordinarily important. Either that sometimes when we cover things too generously, we cover things that we shouldn't. And I worry, as someone who cares more about high value care than low value care, that we actually have too blunt an instrument that's going to prevent someone who actually needs that vitamin D test. There are a few out there as we try to push back against low-risk patients getting population screening. So the phrase that we use, and I don't think either Michael, myself, or Beth really explained very well, is this term called the waste index, which is of 100 times a service is used in a setting that we can identify from claims in a very conservative way, our estimate that the service is either of very low or low value. And why the Low Value Care Task Force and much of Beth's dashboards are not picking the things that are most common, costly, or dangerous, but picking the things that have the highest waste index, because we really don't want to rock the apple cart. And most importantly, we don't want to put barriers in place for patients who actually need care. So even if we get as close to right as possible, it's extraordinarily important that an appeals process in place for that very rare person who needs to get her vitamin D checked can get her vitamin D checked without having to pay full price. And like prior auth and other restrictions we have on the high value care side, we have argued from the VBID Center perspective that the same process should be put in place to identify an instance, maybe rare or not, where something that may be deemed low value care is actually high value care and the patient should not be penalized. Even though that might be onerous to clinicians and providers, I think the current alternatives of super blunt instruments like deductibles that make all services inaccessible and high cost because of their lack of nuance would suggest that dividing up services into high and low with an appeals process would be a step forward upon what we have already.
Great, thank you, Mark. And Beth, do you have anything to add?
I would agree. You know, one of the things that I think it's important to point out to folks is that when we look at the data, it tends to be extremely conservative in its approach, and that when we talk about making improvements, so for example, when we're looking at an initiative to improve reducing unnecessary preoperative testing, we're talking about a 25% improvement. And, we're looking at numbers that, as I mentioned, I think in Virginia, just that one is over 200 million in Virginia. We can do better without it being blunt and without people losing access to services that they really need.
Great, thank you. And Mark, you mentioned one quick health waste calculator question to answer. You mentioned that the next version would have 400 different services. Is that correct?
That is. I'll make sure that we all send out contact information from my colleague Katie Spangler, who can answer all easy or difficult questions regarding health waste calculator.
Okay, great. And so I would assume then someone asked a question about understanding if we've been able to measure the follow-up medical costs due to low-value care, such as the labs, the procedures, things that come after someone has received low-value care. And I assume, Beth, based on what you just said, these estimates are conservative. So we don't actually know much about those follow-up costs.
Absolutely. That's, the thing I want to point out to folks is that we aren't capturing any of the cascading harm from any of these tests and procedures. And we aren't capturing things like, that impact the individual, the time, the wait times. We aren't talking about things in terms of, providers have shared with me that when they run some of these, and I will share with you, sometimes they're required to run some of these because there are standing orders at their health system that require it, even though they know it shouldn't be done. And so when they do these things, then they have to follow up on them. So there are many other costs than just that initial test, but the numbers that I've given you are just those initial tests.
And yeah, I'll quickly say that there's a paper in JAMA this week that we'll have on the Task Force for Low Value Care website shortly that is one of the first, it's from Australia, to measure the substantial downstream costs that Beth and Mike mentioned.
And Beth, when you've been doing this measurement using the health waste calculator in Virginia, have you been able to identify the differing rates by payer type, like between Medicaid, between commercial plans? Is that data that is available?
Sure. So we are able in Virginia to look at the data comparing Medicare's performance, commercial and Medicaid. What we don't know yet and haven't been able to do, which is why I typically don't share those numbers, is that they're not risk adjusted.
Right.
And so that will be a next important step. But we can look at it, and I will tell you what we have been able to get from that. And this probably won't be that surprising, but because those are different populations, what tests and procedures wind up in their kind of top 5 list are different. And the last piece I'll share with you is, even at the risk of not having done the risk adjustment, it looks like our biggest challenge is actually with the commercially insured. Their numbers are significantly bigger.
Great. And with the final minute, there's tons of questions I could ask, but do either of you have any closing remarks about where to start with low value care? Beth, you are familiar obviously with the state's perspective, how to get started. So if either of you have any closing comments on that, and for anyone who has asked a question that we didn't get to, if I have your information, I will follow up with you as quickly as possible.
Sure. I would just encourage folks, I think on your very last slide, Michael, you have a link to our website. And if you go there and you click on, what do we do? You can, and if you're a data person, you can geek out there. You can go and you can look at a waste calculator report that gives you by test and procedure, and you can look at all the information. You can see our dashboard measures. You can look at them by region of the state, so all of the data is there. And I'm happy to answer any questions folks have. Just shoot me an email.
Great. Mark, any final comments?
No, I just think it's very fortunate for us and unfortunate for purchasers that there's so much low value care out there as payers are increasingly strained to figure out ways to deal with the underinsurance problem. I do think that while we work out value-based payments and alternative payment models, we do have an opportunity to find some funds to reduce the cost-related non-adherence issue by going after these low-lying fruit.
Well, thank you everyone for joining us today. It's 3 o'clock, and so we're going to conclude the webinar, but there are questions that are outstanding, and I will attempt to answer them right now. I will also follow up with anyone by email. My contact information is at the bottom of your screen right now, boudros@vbidhealth.com. You can visit all of our websites to see more information about the foraging, and we really appreciate you spending the time today. The slides will be shared on the website. There will be a link in a follow-up email tomorrow where the slides will be located. If you have any desire to continue this conversation, please reach out. Thank you very much.
Thanks.
Thank you, Beth.